Good evening, good morning, sorry. This is the white wine of last night. Maybe it's me after the dinner, but maybe it's the biology in the world with the accreditation. In France, I used to present this to say to the other biologists of France to wake up because it's time to go for accreditation. So, the subject of the topic is when true life, mine, in an ISO 15199 clinical lab calls for harmonization. I will speak only about things of the day, of every day. So, I'm staying in Nantes. It's on the west coast of France. And my lab is fully accredited since 2007. And for the whole activity, 1 million tests a year. And it's biochemistry, microbiology, infrared spectroscopy. I'm specialized for this. Hematology, immunohematology, allergy, autoimmunity, parasitology, and mycology. So, the purpose of this topic is to take few examples from true life in a lab, focusing on need for harmonization for pre-analytical step, analytical step, quality management system, because you know the devil is always in the details in each part. So this is an abstract from our last management review for the year 2011, and the first diagram is showing the non-conformities we recorded about in the lab, 700 non-conformity in a year, and 68% are from pre-analytical step. Okay. And when we check about pre-analytical non-conformity distribution, we can see that 83% are from external samples. Okay, what you should say? Oh, you have to explain to the phlebotomist, to the clinician, how to improve this. So I did it 5 years, 7 years or longer. I spent a lot of time doing emails, doing newspaper presentation, and it's always the same old story. Every time we have the same problem. So where are the reasons? Alors, first pre-analytical fact about urine samples. I will show you some abstract from the next ISO 15199. This is the project. And in the chapter 5442, Instruction for Pre-Collection Activities, it's written that the laboratory's instruction for pre-collection activities should include the following: preparation of the patient, type and amount of the primary sample to be collected, special timing of collections, and then in chapter 5443, instruction for collection activities, you have to indicate information and instruction regarding suitable specimen containers and any additives needed. This is good requirement. Now, let's see about clinical needs, because we need to be near the clinical needs. And about renal stone disease. About 8 to 10% of the population is suffering about urinary lithiasis. The cost of renal stone disease in France, it's about 115 million euro a year. And you know, it's about 50% of recurrence in the 5 next years. And in some cases, the end term will be renal failure. And today in France, we know that 1,000 of patients under chronic dialysis due to renal stone disease. So in that case, prevention of recurrence is essential and needs first correct identifications of factors for stone genesis, and then for dietetical recommendations and compliance of patients. So urine analysis is an important step to explore metabolic disorders such as hyperoxaluria, hypercalciuria, hyperuricuriا, and hypocitraturia, for example. You know that there is a relationship between the pH and crystalline species. Each species has its own pH for crystallization, and for example, dehydrated uric acid will crystallize in the pH 5.20. Meanwhile, Vevolite, which is a monohydrated calcium oxalate, will crystallize nearby 6. So this is important to know because you have to prepare the sample to realize the exact test for uric acid concentration or calcium concentration. You have to check the pH and to adjust it. So, the French Society of Urology recommend about urinary biochemistry in urinary lithosis to sample on 24 hours the urine and to put additive. For example, calcium, phosphorus, magnesium, you have to put HCl. And for the creatinine, urea, and sodium, it's without any additive. And with the uric acid, you have to put sodium hydroxide. Okay, this is the first idea. In the Annals of Clinical Biochemistry, in the year 2009, there was a very interesting paper about acidification and urine calcium. Is it a prenatical necessity? In the conclusion, the authors said, our results suggest that the acidification of urine samples is not a prenatical necessity for the measurement of urine calcium. Okay, two scientific societies and two different recommendations. I think there is a need for harmonization, for sure. Now, let's see what about the instructions from manufacturers for calcium testing. Roche say, urine is collected in acid wash bottles. For sure, you have all in your labs acid wash bottles. And then Herbert and Horto say, collect in a bottle containing 20 milliliters of 6-mole HCl. Why not? Now let's consider for the uric acid testing in urine. Roche say add NaOH prior to sample collection. Meanwhile, Albert said add 10 milliliters of NaOH 12.5 in. It's very concentrated and very dangerous for the people managing the containers. So they did. And Horto said do not alkalize specimens. That's something wrong, I don't know where. I know where. So, about true life for labs and patients. Generally, lab recommends this practical and simple way. The patient should collect urine over 24 hours without any conservative agents, but keep it in cool place. And then the laboratorian should put acid or alkali in a sample of urines after mixing the whole. For sure, it's the best way. But from some ISO assessors who know about true life in this kind of lab, this is okay. Meanwhile, for other one, this is not okay, and it means non-conformity. Another need for harmonization. Second prenatical fight about serology. Once again, I will speak about the clinical needs, about seroconversion. In France, it's mandatory to keep frozen samples of sera for each serology for 1 year. We may have to check fresh sera and frozen sera together in order to detect seroconversion for Rubella infections and Toxoplasma infections. For COFAX assessors, we must follow exactly the instructions given by manufacturers unless it's non-conformity. I got this kind of non-conformity, and the assessors say it's a critical one. We'll see now. About the preparation of frozen sample, and I took the package insert of Abbott Toxo-J. And he said, sera should be centrifuged at 10,000 G. Can you imagine what does it mean? So, if you use this kind of device, you will never get it, of course. And if you use these fully common devices, this is the same. We ask about this. Oh, we have to check with our lawyers. What? I need an answer in the 3 months because I've got a critical non-conformity. Oh, I'm sorry, we can't do it. Maybe in some years. My God. So, preliminary conclusion number 1. We, 151N9 biologists, must advocate for harmonization in the pre-analytical steps, that's sure. We must explain to assessors that the good quality in healthcare is not only compliance to instructions from manufacturers, but first of all, management of good samples. Manufacturers' recommendation for pre-analytical should take into account the idea that the patients need simple and logical things to do. We, 151N9 biologists, must help manufacturers in that way by sharing our experience together. And we'll see later how to do it. Now, let's check about an analytical fact about calibration and calibrators. And I say when we are bound to the manufacturer. I hope there is no manufacturer in that room. The DREAM, this is the ISO 15189 project, chapter 5324, equipment calibration. The laboratory shall have document procedure for the calibration of equipment that affects examination results and that record the metrological traceability of the calibration standard. Okay, that's the DREAM. Now, I received the promise of life, for life. This is a paper from the manufacturer, I won't say the one. The assay AFP2, and on the right part, you will see the reference material standardizations. It's WHO, First International Standard, 72225. And you can see the uncertainty, 0.18. Good. Interesting. I'm happy to see it. But what is true life in my lab? So this is the quality control in FP using 3 levels with URT, BIARD. And we have changed a lot of calibrators. And we can see a proportional bias. We asked the manufacturer, hey, what happened to your calibrators? This is a very good one. This is the best one for sure. And you are the only one who complained about it. Yeah, I know this is the same old song. I can sing it to you now. Few weeks later, they call me once again. They say, oh, sorry, you were right. But next lot of calibrators will be available only in 1 month. For 1 month, I never can do any AFP more. It's crazy for the patients, for the clinicians, and for the lab. So preliminary conclusion, number 2, we know how it can be difficult to manage a supply chain of lots of products. It's, of course, but labs can be prisoner of the lean management policy of their manufacturers. The real sense of quality is to give priority to the satisfaction of patients and physicians, and we need that manufacturers help labs in that way. So the last point of my presentation is about quality management system. Yesterday, many people, very brilliant people, were speaking about quality, Six Sigma, risk management. What about the mystery of risk management? I'm not a teacher. The new deal for the future is in the ISO 15189, Chapter 4.14.6, Risk Management. The laboratory shall evaluate the impact of work processes and potential failures on the safety of the examination results and shall modify processes to reduce or eliminate the identified risks. And this is naturally linked to the Chapter 5.6.2, Quality Control procedures that verify the attainment of the intended quality of results, for sure. So that's the new deal. What do we do to prevent risk? We do quality control, of course. But the real question are the following one. What kind of quality control to prevent what kind of risk? Do our quality control strategies fully prevent the risk? And which tools and guidelines can help us? First of all, how to assess risk? We must define the risk. Do we use 2 or 3 variables, severity and occurrence as it's set in laboratory guidelines, or severity plus occurrence plus detection as in industrial guidelines? Then we must give some priorities with ranking scales. About ranking scales, do we use 3 or more categories? 3 categories and quantitative as in ISO 14971, or 5 categories semi-quantitative in CLSI EPIN 23. What kind of tools? Today in France, we used to apply process map, but it's not enough by itself. You have to use qualitative approach or maybe quantitative approach or both of them. But you know, FMEA, it's time consuming. You have sigma metrics, you know many things about it now, and risk matrix. But if we are speaking about sigma metrics, the results are speaking by themselves. These are my sigma metrics. As you can see, calcium is under 3. I don't speak about the last one. It's a nightmare. And I asked to the manufacturer, how would you help me? Oh, we don't know. You are the only one who showed this. My God. So the final idea is to define the quality control plan with the quality control frequency, the statistical quality control design, you know it since yesterday, and to evaluate the residual risk. But it's a real challenge for harmonization. Biologists need some practical guidelines to help them in building their new strategy for quality control and risk prevention. Manufacturers must improve methods and technologies for which the sigma number appears to be really terrific. The way for calculation the number of sigma needs harmonization too. Mr. Jeremy Grass spoke about it yesterday. In conclusion, I have a dream. But don't shoot me, I'm only the piano player. No, wait. Oh, I can leave you now. Harmonization, why not? But how to do it? The scientific society should work together in order to publish universal guides for practical considerations. There are too many different publications. It's very difficult to organize the pre-analytical step when, meanwhile, you are preparing your accreditation. I spent a lot of time doing this. It's not good. We have to take into account the true life of patients and labs, the knowledge in medicine and clinical needs. This is the most important part, clinical needs. Manufacturers must improve their analytical systems. We cannot accept any analytical methods with a number of sigma under 3. But we have to inform manufacturers about our difficulties. I'm sure that many labs never call the manufacturer to say, oh, I got some problem with my calibration and quality control. Why do so? We should exchange more information with manufacturers about true performance of analytical systems. For example, to do a survey about sigma numbers. But first, we have to define how to calculate the sigma numbers. We should share our experience in labs. And now I will speak about an experience we made in France. In France, I've built a web community of biologists since 2004. And it's a professional space only open to biologists and their teams. And we have today 1,200 members who are brainstorming about 15199 requirements and the way to apply them. Since 2004, we have 40,000 messages. It's very interesting. And we have a searching machine engine who help the people to understand how to apply the requirements. The moderation is assumed by biologists. We are managing accredited labs. And our goal is to create a new space, English spoken, of course, because you know French is not a very common language, in order to extend it to other countries. So that's all, folks. And I'll repeat, okay, I have a dream, but please don't shoot me. Thank you.